induction of labour is a process designed to artificially start your labour. Around 25% of all women will have their labour induced. You will have had a discussion with a doctor or a midwife to make a care plan for you. They will give you all the pros and cons of the induction process and you can make an informed choice. The length of time the process can take can vary considerably for each individual. Unfortunately, there may be times where there is a delay in your induction process. This can be very upsetting. However, please be ensured that we will monitor you closely throughout the delay and we are assessing each individual on clinical need throughout this. Some of the reasons that we induce your labour are that you have gone overdue by 10 to 14 days, you may have diabetes, you may have a pregnancy-related condition such as obstetric cholestasis or high blood pressure. Your baby may be measuring smaller or larger, or your movements may not be as good. You may already have a pre-existing medical condition where the doctors would advise you have an induction. These conditions will be discussed with you and your doctor and a plan will be made. There are different areas that you can have your induction started in the Rosie. If you are low risk and haven't seen the doctors throughout your pregnancy, you may be offered an outpatient induction. This is where the induction is started in the Rosie and you are then sent home. This would be commenced in Clinic 23. During your time at home, you would be able to contact the clinic at any point and come back in for assessment. It is vital that whilst you're at home, if you start having contractions or your waters break or you're worried about the baby's movements or any concerns, you contact the clinic straight away. It may be recommended that you have your induction started in the hospital and remain as an inpatient. Most inductions are started on Sarah ward. When you are admitted for induction, you will have a care plan tailored for you by the obstetricians that are caring for you. To commence your induction, we will use a medication called prostaglandin. The prostaglandin is designed to soften the neck of your womb or your cervix. There are two ways that we administer prostaglandin in this trust. If you are a first-time mum and you are coming into an inpatient induction, we would use something called a ProPes. We would also use this for first-time mums having an outpatient induction. A ProPes is a small pessary that sits just behind the neck of the womb. This would be inserted by a midwife on the ward after the full assessment has been done. This can stay in place for up to 24 hours. It has a small string just like a tampon, so can be removed at any point. The aim of this ProPes is to soften your cervix and dilate it enough for us to be able to break your waters. If you have had a baby before or you have had the ProPes for 24 hours and require further prostaglandins, we can use a Prostin tablet. This is inserted by the midwife on the ward and sits behind the neck of the womb. This tablet will be given after all the assessments. It will dissolve over 6 hours and you will be reassessed after this. You may require more than one tablet. Once the tablets have been effective and your cervix has softened and dilated, you are ready to be transferred to the delivery unit to have your membranes broken or your waters ruptured. This cannot be done on Sarah ward because you need a one-to-one midwife with you. There can sometimes be a delay with this due to the activity and the capacity of the unit. Your waters are broken by a midwife or a doctor examining you and passing a small hook through the fingers and piercing a hole into your membranes. This allows your waters to be released and it increases the pressure from the head on your cervix. You will be given a couple of hours to establish labour by yourself. If after a few hours you have not established regular contractions, you will be offered an oxytocin drip. The oxytocin drip or syntocinon infusion is an artificial hormone that will start your contractions. This is commenced at a very small rate and increased gradually until your contractions are regular and strong. Whilst on the syntocinon drip, you will be monitored continuously by a one-to-one midwife. Most of our inductions are started on Sarah ward. During your time here, one birthing partner can stay with you at all times. Please be aware that due to limited space, we cannot provide sleeping spaces for these birthing partners. We do have some reclining chairs. Sarah Ward is a single-sex ward, so we do not have showering or toilet facilities for birthing partners either. There are toilets situated just outside the ward. The ward can provide you with a birthing ball and a TENS machine if you don't have one. We regularly use simple analgesia such as paracetamol and dihydrocodeine. It may be helpful for you to bring in a water bottle for your back pains and your own pillow and mug for comfort. Whilst you are being induced, please remember to inform a midwife or a member of staff if you have any concerns. If you're worried about your baby moving, if you have any contractions or any bleeding, or you think your waters may have broken, please let us know straight away. Whilst you're being induced, you may find it helpful to express some milk. This can be stored and given to the baby if they need it. There is plenty of information on the ward about doing this, or ask any member of staff to help you. If you have expressed milk at home and are bringing it in frozen, that's fine. We can store it on the neonatal unit for you until you require it. Please limit the amount of luggage you bring onto the ward. There is limited space around the bed and we need to keep you and the staff safe. It is important to mobilise whilst you are being induced. You can mobilise around the ward, or if your midwife thinks it's suitable, you are free to go off the ward somewhere such as the concourse. As we said before, we cannot predict how long the process will take. There may be times where your induction is delayed because the capacity does not allow us to continue. We will monitor you throughout this time and we will keep you updated. We have to prioritise who to continue on a clinical need.